Right. The lecture today is all about blood pressure control, which is now the current problem in hypertension. So it's not so much about drugs and drug treatment, but how to achieve control. Now, this is the disclaimer slide from Novartis, which just says they don't agree with me, and I don't agree with them necessarily. So the first question that I've asked myself is, what is the impact of hypertension globally? And I have one slide on that. If you look at the prevalence of hypertension, what is for me critical, look here, 349 million people with hypertension in high-income countries currently. But if you go to middle and low-income countries, it's 1.04 billion people with hypertension. So there's a clear shift in the prevalence of hypertension from high-income countries to middle and low-income countries, which were not there a few decades ago. And not only has it shifted, but now hypertension in middle and low-income countries are much more younger people with hypertension. So you can imagine what the impact would be financially with young people with complications of hypertension. So a high systolic blood pressure remains the leading cause of premature death globally. Number 2 is smoking anything, and high blood glucose. Hypertension itself causes 10.4 million deaths per year globally. And globally, irrespective of income of the country, blood pressure or hypertension is increasing. So what is the impact? I think this is a tremendous impact. And the problem is that hypertension is virtually asymptomatic. So there are so many people that's left without a diagnosis. Now, let's look at the definition of hypertension, because there's a little bit of controversy. Universally, blood pressure equal to 140/90 or higher than that in all people, including the elderly. They don't really define whether 90 is elderly or 60 so many people will say 65 and above. UK, Europe, South Africa, International Society of Hypertension use this definition. And this you reach after repeated measurements in the clinic. Ideally, you should also do an out-of-office measurement, like a 24-hour ambulatory or a home. Because the point about this is we must be sure about the diagnosis, because the treatment is virtually lifelong. The thing to remember is that this definition of hypertension at this blood pressure level is a pragmatic decision. And it's probably the best definition where the benefit of treatment will outweigh the side effects. The United States of America says no, hypertension is above 130/80. They based it on one huge trial, the SPRINT trial, which remains controversial until today. Many other people outside the USA agree that a blood pressure of 130/80 would need treatment for hypertension if the total cardiovascular risk is high. In other words, there's lots of other risk factors present, or there's target organ damage. So I think this is a pragmatic sort of definition to say, yes, this is definition 140/90, but you can start treatment if the risk is high. And I think it's practical. We can use this in practice. Then, what about the target blood pressure? And here I want to show you mainly the International Society of Hypertension. They were published in 2020, and they divided blood pressure or hypertension care in two things: essential and optimal. Essential meaning this is the minimum standard. And there's two things. Ideally, everyone should have a blood pressure below 140/90 on treatment. So that is the goal, the control. Or if you can't achieve that, at least reduce blood pressure by 20/10. 20 systolic, 10 diastolic. And this figure comes from a very large observational study of more than 1 million people to show that if blood pressure goes up by 20/10, you double cardiovascular risk. If you reduce it by 20/10, you half the risk. So minimum standard are these two things. Optimal care is something different. This is the best you can offer. Below the age of 65, try and aim for a blood pressure as close to 130/80 if tolerated. But please do not go below 120/70. If you're older than 65, below 140/90 would be optimal care if tolerated. But beware of frailty in old people. And then just this little rider, do not go below the systolic blood pressure of 120 for everyone, because there is definite harm. Although there may be a slight stroke benefit, there is definitely harm below this level. So I think for me, this is a very practical thing for practice. Essential, the minimum you can do, and the optimal, the best you can do. Now, let's look at, does everyone benefit from hypertension? And I just brought one meta-analysis already published in 2014 by the Blood Pressure Lowering Treatment Trialist Collaboration. And what they showed is they looked at the blue, which is low-risk hypertensives, and the red, high risk. And if you reduce blood pressure slightly by 4 millimeters, low risk will benefit, high risk will benefit more. If you bring down blood pressure systolic by 60, it's not even the 20/10. Low risk, 18 out of 1,000 will benefit, high risk, 69 out of 1,000. So the point about this slide is it does not matter how much you reduce the blood pressure, how high the risk is, everyone will benefit. The more you reduce the blood pressure, the bigger the benefit. The higher the risk, the bigger the benefit. So the fact that the blood pressure is elevated puts you at risk. The fact that you treat it will reduce that risk, will not eliminate it, but will significantly reduce the risk. So what about diastolic blood pressure? We don't often hear about it. In the 1960s, when the first trials were done on hypertension, they only looked at diastolic blood pressure. Now, if your diastolic blood pressure untreated is between 115 and 119, the numbers needed to treat over 5 years is only 3. You only need to treat 3 of these people to prevent the first cardiovascular event. But if you go too low with diastolic blood pressure, and the figure to remember is probably 60 millimeters of mercury. Now, why 60? 60 millimeters of mercury is the minimum that you need to fill the coronary arteries with blood. So if it goes below, you may get myocardial ischemia. And the way to test that is do a troponin level. If the troponin level increases with a low diastolic pressure, it means the diastolic blood pressure is too low. Because remember, coronary arteries fill in diastole. So yes, diastolic blood pressure reduction is important, but do not go too low. So this is also, I think, of practical importance. If you're worried, you don't know, do a troponin level. If the troponin is increased, the blood pressure, the diastolic is too low, then you have to put a brake on the treatment. Now, what about monotherapy? Will monotherapy control blood pressure? And I only brought one slide from one meta-analysis, the Tumopoulos. There are other which shows exactly the same. And the point about monotherapy, one blood pressure pill, all drug classes reduce cardiovascular disease. Doesn't matter which one you use. But there are differences for specific outcomes. A few examples. Diuretics protect you from heart failure better than any other drug. Although diuretics also reduces all the cardiovascular events. Beta blockers reduces events, but it does not protect you from stroke. CCB, calcium channel blockers, the dihydropyridine like amlodipine, superior stroke protection and all-cause death, but it doesn't prevent you from heart failure. ACE inhibitors, superior coronary heart disease protection, less effective in stroke as a single drug. ARBs as a single drug, better stroke protection, but incomplete coronary heart disease. So the point about this is no single drug that is the best for all outcomes. Every single pill has got strengths and weaknesses. So it's very difficult as a doctor to rely on one pill. Because if you now protect the brain, what about the heart? What about the kidney? Therefore, I think globally, everyone is moving towards combination therapy. Let's just look at the European Society of Hypertension Guidelines 2018. Step 1, combination therapy with one pill, a single pill combination with 2 components for all patients as a first step. And a RAS blocker, renin-angiotensin system blocker, either an ACE or an ARB, is the foundation of treatment. So what they suggest, a RAS blocker, ACE or ARB, plus a CCB, or a RAS blocker, ACE or ARB, plus a diuretic. Now there's lots of controversy and discussion around the type of diuretic, but many of these huge guidelines do not really distinguish between a thiazide type and a thiazide-like. Thiazide type, hydrochlorothiazide. Thiazide-like is indapamide. Now, the British and South Africans favor indapamide, but diuretic is what the guidelines say. Now, if you combine a RAS blocker with a CCB or a diuretic, it removes, like in the old days, issues in deciding which drug based on age or race or ethnicity. Remember in the old days, they said if you're less than 55 years, you start with an ACE. If you're older than 55 or black, you start with a CCB. Now, this combination has removed that because this now covers everyone. Monotherapy still has a place for the very elderly and fragile patients, and maybe a very low risk stage 1 hypertension, but very limited. Why do they go for a single pill combination? And we come back. It improves the speed of blood pressure lowering, which is critical. It improves the efficiency of blood pressure lowering. So blood pressure lowers much better than a monotherapy. It improves control, and it improves, probably the most important, improves adherence. You can maybe also add there, number E, it simplifies the treatment regime. You take one pill per day, and that's that. So this is, I think, globally, the American guidelines, the European guidelines, the International Society of Guidelines, the British guidelines, the Canadian guidelines, the Latin American guidelines, all have the same basic foundation. Now, coming back to the International Society of Hypertension, they, in terms of the treatment, they also have essential of minimal therapy and optimal therapy. Now, their optimal, the best you can do, is to start with an A plus C, a RAS blocker, ACE or ARB, plus a calcium channel blocker. Both of them in a half dose, in a single pill. And if that doesn't work, the same combination, but now in full dose, single pill. And they also have a place for a RAS blocker and a diuretic, specific indications. For instance, post-stroke, diabetes, people who are at risk for heart failure, etc. Step three is a A plus a C plus a D, triple therapy. And this is a new avenue that's being explored, that there are drugs coming on the market, already on the market, single pill with 3 components: a RAS blocker, a calcium channel blocker, and a diuretic. Now, essential or minimal therapy, it says use whatever drug is available, or use a free combo if the single pill combination is not available. Use a thiazide if thiazide-like is not available. So it shows you how pragmatic the International Society of Hypertension is. Now, why? Because it caters for people with money and medical aids, and it caters for people without any care or support whatsoever. The essential therapy, just to try and reduce blood pressure. Consider monotherapy, already spoke about it, old people. Beta blockers should not be used unless there's a specific indication. Hypertension plus heart failure, hypertension plus atrial fibrillation, hypertension plus post-MI, hypertension plus severe migraine, for instance. So there is a place for a beta blocker, but not as a first line. The European Society of Hypertension, step 1, single pill for all patients. Now, here's a sentence that you should pay attention to. The societies are now saying you should reach control or target blood pressure or goal blood pressure within 3 months. If you postpone control, there's an increase in cardiovascular events. So this is something new that you cannot play around. You have to bring down blood pressure. And that's another reason why combination therapy is in fashion at the moment. Now, this is an interesting study where they looked at the likelihood, the odds that you will have blood pressure control in year 1 of treatment. So they use monotherapy as the reference. So if you have a free combination, in other words, 2 separate pills, the odds or the likelihood is about 30% that you will have control within the first year. If you use the same 2 drugs in a single pill, the odds now is 50%, more than 50%. So the point about this slide is combination treatment is good. Free combination is better than monotherapy. Single pill is better than free combination in terms of control. So this is a very nice study quoted by virtually everyone. Another that we've already forgotten, which comes from 1982, the Hypertension Detection and Follow-up Program. What they did is they looked at the percentage of outcome in 5 years. If there was no organ damage, no proteinuria, LVH normal, everything normal, you can see there is a significant reduction in outcome. But if you have organ damage, there's a significant reduction in outcome. But look at the massive increase in residual risk. So what does it mean? It means if you wait with hypertension until there's organ damage and then start to treat, you will get a significant reduction in risk, but the residual risk, the chances of developing another stroke or myocardial infarction is almost 3 times higher than when there was no organ damage. We've forgotten about this. So you should start hypertension therapy as soon as possible. That's the message. Now, I want to come back to the value trial to show a specific point. It was 15,000 people with cardiovascular risk factors, hypertension. They sort of compared valsartan, an ARB, versus amlodipine, a CCB, Both arms got hydrochlorothiazide, so we can ignore that. So the primary endpoint between valsartan and amlodipine in terms of cardiovascular morbidity and mortality was exactly the same. There was no difference between the two. But on re-evaluating the data from this trial, two important pieces of information came to fore in terms of how we treat blood pressure. The first one is the significance of early control. Remember the guidelines now, this is an old study. The guidelines now say within 3 months. So early control, we saw for the first time here. The second is the issue of persistence of control. So let's look at the data. So here, published in the Progress of Cardiovascular Disease, observational study using data from the Valley trial, they looked at early responders in terms of blood pressure reduction versus non-early responders. Now, here's the odds ratio of 1. Early response, non-early response. Now, early responders had a significant reduction in cardiovascular events, stroke, but not so much death, not myocardial infarction, and not heart failure. So suddenly we realized with this trial that you cannot, like in the old days, take your time to control blood pressure because there is significant benefit in early responders. So you want to get that blood pressure down as soon as possible. Now, there's another, we use the value trial, but also the all-had trial. Remember this, they used 24,000 patients out of the original 44,000. And what they did was something that you can do in practice. Every time you see the patient, when you measure the blood pressure and it's below 140/90, in a year or 6 months, you can work out what is the percentage of visits where the blood pressure was controlled. So both studies were published and both used at least 4 measurements in the 3 or 4 years of the study. So every time you measure the blood pressure, you measure it twice with a minute or 2 minutes in between. You take the average and then you work out the proportion of blood pressure measurements that was below 140. And they divide it into 100% of the time you control, 75%, 50%, below 50, 25, below 25. So you can do that, whatever. And for each, the incidence of cardiac events were calculated. So let's have a look at the results. Now let's look at the value trial. If you were controlled only about 25% of the time, myocardial infarction rate was 6.8% per year. If you were controlled for 50% of the time, it dropped to 3.6%. If you were controlled 3/4 of the time, it dropped slightly further. Stroke, 7.5, 3.2, 2.3%. Heart failure, 8.42. So the point about this is an easily measured matrix. How many times in percentage were the blood pressure controlled when you saw the patient in your practice? Because the more often it is controlled, the less the events. So here comes this whole issue of blood pressure variability. So one should be very careful to disregard a blood pressure that's not under control. Let's look at the all-had study. They used it a little bit different. 100% of the time control, myocardial infarction, absolute risk reduction was 9 to 13 per 1,000 people. 75%, it went up to 10 to 14. Less than 50%, 12 to 15 per 1,000. Stroke, 4 to 6, 4 to 7, 8 to 11. Heart failure, 7 to 11. And if you're less than 50%, 15 to 18. So we have 2 studies that looked at the percentage of times that you see the patient where the blood pressure is controlled. And the bigger that number, the less the events. The worse that number, the lower, the worse the outcome. So I think this is a practical thing for practice to measure control. What about blood pressure delay? And this is a Spanish study that showed from diagnosis to control time, the longer you take, the higher the mortality. Again, this whole issue, control quickly. This is a study from Australia that showed if you persist with your pills, your outcome, your mortality with a single pill is better than anything else. So, conclusions. Hypertension is an important treatable cardiovascular risk factor. It remains poorly controlled. Combination therapy is the preferred. Please do not rely on monotherapy. Bring down the blood pressure within 3 months and check for control. Thank you for your attention. There are the references.